So the second talk I've been asked to give is a review about amplitude integrated EEG. Obviously, it will not be a comprehensive review in 30 minutes, but I sort of wanted to explain the concept so that you would know how to apply it and what the pros and cons are. Again, no conflicts to disclose. Obviously, I may be mentioning some seizure medications, which are obviously off-label since there have been no real phase 3 seizure treatment trials done in newborns. The objectives are to describe the basic principles of amplitude integrated EEG so that you understand the concepts to know in what ways you can use the A-EEG and what are the pros and cons of the A-EEG, or when should you be ordering the EEG based upon what you see or what you cannot see on the A-EEG. So let's start with the basic principles. This is a picture of the very first EEG. And as you can see, this is not a device that is going to be, moved into the patient. It is not going to the patient. The patient is going to go to the EEG device. In the US, the first EEG department was at Piedmont Hospital in Georgia in 1947. And as you can see from the picture, this EEG device looks a little more portable than the very first EEG. However, it's still pretty large in length. It's about 2/3 the length of this patient's exam bed. This is the EEG that I grew up with when I started as a neurologist. It was a paper EEG. And this came about and became more used in ICUs when ICUs became into creation in the 1960s after the resuscitation after cardiorespiratory arrest, and then more specifically with cardiac and transplant surgeries. In particular, because you could have brain insults after these complex surgeries, and also because these patients often post-operatively were sedated or paralyzed, and therefore you lost the ability to use the neurologic exam as a functional assessment. In the 1970s, the first neurologic ICUs came about, allowing for continuous prolonged EEG. However, just imagine trying to do prolonged continuous EEG with this paper EEG tracing. When I was training, we would instruct the ICU bedside nurse to turn on this paper EEG for 1 minute every hour to get a continuous intermittent tracing, but you would still have to send someone up to get the paper about every 3 or 4 hours because you would have a stack of EEG tracing about 2 or 3 inches thick, and that would then overflow this paper tray and it'll be on the floor. So obviously you can see the barriers of performing prolonged EEG recordings at the bedside. They were bulky. The medical bed spaces back in the day were much smaller than they are now. It was difficult to be able to gauge gross change in trends over a period of minutes, much less hours or days. There'd be an enormous amount of paper that you would have to collect and send the EEG technologist to bring down, and definitely no ability to bedside remote to be able to tell you what was going on in real time. And then obviously you needed technologists who would be able to place the leads, know how to manage that EEG machine if the pen wasn't working, and also the technical skill to interpret it. So this is why A-EEG, whereas the algorithm for amplitude integrated EEG, was first developed in the 1950s by Maynard, Pryor, and Scott. And what they were trying to do is compress both the amplitude and actually the frequency features of an EEG into a compressed time point or compressed, a tracing. And so despite what the name implies of amplitude integrated EEG, A-EEG is not just about the variance of the amplitude of the EEG, but it also captures some of the frequency features that are seen in EEG, because it applies what we call a band pass filter, meaning for EEG tracing between 2 and 15 hertz, the amplitude is weighted in a linear fashion as the frequency improves. Why 2 and 15 hertz? Because in an adult patient that was getting their post-op heart procedure, the majority of the waveform should be in theta and alpha range. And therefore, they wanted to accentuate that by weighting it in a linear fashion. Frequencies below 2 Hertz, the delta range, which is actually the predominant pattern in newborns, were weighted less. And then especially that in the beta range, anything beyond 12 or 13 Hertz were, again, underweighted because that would be most likely noise. This is why amplitude integrated EEG is actually very good and works really well on newborns, because it's actually showing you both the frequency and the amplitude features of the EEG tracing, but presenting it in a much simpler way for an untrained eye to be able to view it. Now, because most of the amplitude in a normal adult is under 25 microvolts, the y-axis is in a semi-logarithmic fashion so that it highlights and provides us better resolution to see the variance in the amplitude. And so then if you were looking at several hours of recording on a newborn, you would very easily be able to see the change in trends as the baby went through alertness, awake, and quiet sleep, just by getting an aerial view. And again, being able to see that step away and being able to see that EEG tracing over hours rather than milliseconds and seconds. Because A-EEG looks at not just amplitude, but also frequency, the frequency, the percentage of frequencies changes as you go from extreme prematurity towards term gestational age. It also goes from being a discontinuous tracing, meaning you have a burst of brain activity and then a suppression of brain activity, and it gets that period of discontinuity gets shorter and shorter as you approach term age, when it then is continuous in both the awake and sleep states. So that you can also use the A-EEG to be able to tell you maturation or just an age in terms of whether they are appropriate for age or not, or even be able to guess the gestational age if you didn't know that by just looking at the tracing. Now, a routine EEG has 18 electrodes placed in a standard, what we call a 10-20 system. Obviously, this would be very hard to place on a 24-weeker. And then just the process of applying these electrodes so that you have good contact with low impedance to get good electrical signal would be difficult on a 24-week preemie who was just born, because that would be undue stress and may be unsafe for that baby. So again, Maynard, Pryor, and Scott limited their electrodes to 2 electrodes rather than 18. And why did they choose that? Because again, this was developed for the adult male patient that was coming out of their cardiac surgery. So by putting it in the parietal regions, they avoided any nearness to the temporalis muscles that would be triggered if you were to bite or chew down on your ET tube. And also the most likely insult after having had some type of major cardiac surgery would be a hypotensive insult. With a hypotensive insult, you would get a watershed pattern or a parasagittal pattern of injury, which again, by placing the electrodes in the parietal area, that one would be likely to capture. Now, since the original CFM or amplitude integrated EEG, there's been other vendors and where they've actually allowed the ability to place more electrodes. So of course, the more electrodes you place, the more coverage, scalp coverage you're going to get to be able to see what is functionally going on with more geographic locations of your cerebral cortex. So if you ask me how many electrodes do you want, as many as you can, and just recognize 2 or 4 is actually a psychological restrictions. You can actually do an amplitude integrated EEG of all 18 channels, and it doesn't have to be only 2 or 4 electrodes. So let's review the applications of A-EEG. So when can you use A-EEG? The exactly same situations and indications that you can use an EEG for. They can help identify encephalopathy, gauge the severity of encephalopathy, be able to tell you whether that encephalopathy is getting better or worse or the same. It can also is a good screening tool for seizures. in terms of telling you which patient might be seizing. And so if there is infants that you have are at high or low risk, but you still are concerned, you can use that as a effective screening tool if you don't have ready access to the EEG, or you want to minimize the cost, being that a full video EEG can be much more expensive than performing an A-EEG. So who do we monitor in our NICU? We don't use the A-EEG in the traditional sense. We obviously offer full continuous video EEG, but the indications are the same. Anytime you have encephalopathy and you want to be able to characterize it, recognize, because an AEG only shows you gross trends, it's not going to give me the resolution of the electrical activity in a millisecond and second pattern as an EEG. So I will not be able to tell you, oh, this type of EEG encephalopathy on the AEG looks more like hepatic versus encephalitis versus HIE the way I can on an EEG tracing, but it can tell you who's encephalopathic and how severe and whether that encephalopathy is getting better or worse. For seizure evaluation and identifying or screening patients for seizures, to pick up electrographic seizures that may not have a clinical correlate. And then obviously, again, also to be able to know whether you're truly in seizure control or not after you've instituted treatments. Since once you add on anticonvulsant medications, the seizures are likely to become electrographic only. They're also likely to get shorter, which is one of the limitations of AEEG in picking up brief seizures. It can also tell you about maturation in terms of whether the baby is age appropriate or not, delayed, or potentially maybe have a congenital reasons for having a static encephalopathy. So an AEG isn't to replace the EEG, it should be as a way to supplement or expand your capabilities if your access to EEG is limited. The video EEG is obviously the gold standard, but perhaps you have a kid on ECMO and the kid's on ECMO for 2 weeks and you don't really want them on a video EEG for 2 weeks because that would be not cost effective and just the amount of time to maintain the contact with 18 electrodes on a scalp of a patient on ECMO may be difficult. This is where an AEG may be very useful. And also for the patient where the likelihood is low, but slightly higher than normal for seizures, that might be a good initial screening tool. However, once you've identified abnormalities on the AEG, you should go over to a full EEG to be able to give you the resolution, to give you more information potentially. When is an AEG not useful? One, if you want to accurately assess the true seizure burden of your patient. So a newborn seizure is on average 40 to 140 seconds. So if your display setting on your AEEG is 6 hours, you can imagine how it would be very difficult for you to visually discern on that AEEG where a single isolated seizure is likely to be if it is less than 2 minutes in duration. Also, you could have overlapping seizures or a cluster of seizures with very short interval of time in between each seizures, and they will look like one single long seizure on the AEEG. And obviously, in certain situations, the amplitude integrated EEG is not going to be useful in letting you know that the patient is acutely decompensating. For example, because you need about 30 minutes of recording to be able to see enough of an AEG tracing, you may not know that your patient is herniating because an EEG will give you a second-to-second view of what is functionally going on with the brain. Whereas in AEG, you need about 30 minutes of recording to see what's going on. And just recognize, again, a traditional routine EEG, depending on the settings of that and the vendor of the EEG monitoring company that you purchase, you're collecting 250 milliseconds of electrical data per second at the minimum. So here you can, is an illustration of how seizure discernment can be limited on an A-EEG. If you have a standard display setting of 6 hours here, as is the typical standard, these little red arrows tell you where the seizure are occurring on this A-EEG tracing. It is very hard to discern. You can then try to zoom in on the A-EEG to a 4-hour window display. And then perhaps you can say, okay, this one, I can see that both the lower and upper margin is deflected upwards. And then likewise here. So this is probably a seizure. This is probably a seizure. But I would say that you're hard pressed to say this is a seizure or this is a seizure, as it doesn't look any different from the A-EEG tracing before and after. If you zoom in now at 2-hour window, you can clearly see these upward deflection of both the upper and lower margin to be able to pick out the seizures even more easily than on that 4-hour display setting. But again, this could be potentially more than one seizure. There's no way for you to discern that on a A-EEG. So A-EEG is good at identifying which patients may be seizing, but it will not be able to effectively tell you the true seizure burden of a patient. You need an EEG to get that level of resolution. And so, again, the more electrodes you place, the better it is. And by having 4 electrodes or 2 channels, not only does it give you more geographic coverage of the cerebral cortex, it also allows you to discern the difference between right or left when you have unilateral injury, which is more likely to occur in an ECMO patient. And then also recognize that you don't have to be confined to a EEG, a dedicated EEG device. So yes, or AEG device. Yes, you can buy a device that only does AEG, but recognize that if you have ready access to an EEG machine, there are softwares that allow you to display trend algorithms in real time in conjunction with the raw EEG tracing, and so that you don't have to necessarily buy a separate device if you already have EEG machines available. And that you can display an A-EEG tracing like you have here, but you can also display many other different type of trend algorithms. A-EEG is just one of over 20 different trend algorithms that are available on, for example, this PERSIST software. So in our NICU, not only do we display full EEG montage, but we actually display above a right and left amplitude integrated EEG tracing so that our neonatologists still have that access to it and can review it, but we don't need to have 2 devices running at the bedside. So what are the pros and cons, and when do we need to go from an AEG to an EEG? So yes, an AEG is slightly simpler and therefore easier to learn than an EEG, but you still need some expertise. You need to know what is a normal amplitude or bandwidth of amplitude for a gestational age, and to know then when it's not normal. You need to know the various ways seizures or status epilepticus will look like on an AEG. And you need to know what state changes, drowsiness, sleep, or sleep-wake cycling, so that you don't mistake it for as being abnormal. And also to know when a change in the background is a deterioration or a static state versus a status epilepticus. And so that does require some experience. And then I think one thing that's was never really discussed a lot in all the studies looking at AEG versus EEG is not about just picking out the seizures and abnormalities, but knowing what are artifacts or normal variants and not over-treating that AEG mistakenly. So I'm only aware of one AEG atlas by Lena Hellstrom-Wosthoff, Linda DeVries, and Igmar Rosen, where they show you different AEG patterns so that you recognize, again, what's normal or abnormal. This is how EEG atlases are written. But more importantly, they tell you what are normal variants or artifacts, because that is the true sign of expertise and ability to be facile with an AEG recording. As mentioned before and also shown in the previous slides, there are different scoring systems that have been validated for preterm versus term babies in HIE in terms of looking at voltage classifications or pattern classifications. So to me, I think using one or the other is rather limited. When we look at EEG, we're looking at the whole EEG, and you can't just look at only voltage or just look at pattern. Both things give useful information. And so that, for example, as you can see here, the AEG in terms of amplitude and bandwidth changes over a gestational age, that you go from being very broad and discontinuous to then having more discrete and well-formed sleep-wake cycling as you approach term infant's age. Again, seizures can be picked out, but again, recognize very brief seizures, a cluster of seizures, or overlapping seizures are going to be difficult to discern with an AEG, because an AEG is about getting an area view of your EEG tracing, whereas an EEG is going to be looking like at your the electrical activity under a microscope. But it will tell you which patient is seizing, even if it may not accurately identify seizure burden for you. So if you're wanting to know seizure burden, an EEG is superior to an AEG. So for example, here, this is a term infant who was admitted at 5 days of life. The red arrows indicate 3 seizures occurring on the right side of the brain. The black arrow is when phenobarbital was given. And then you see subsequently how the EEG normalizes and that regular sleep-wake cycling, it returns in the subsequent several hours. Here, you can see how an AEG could be very useful in giving you a very quick perspective of a patient, that in this 2-hour display that you have multiple seizures going on in both the right and left hemisphere. Each one of these dysflexions or seizures are probably multiple seizures rather than a single seizure event. The black arrow indicates this where we are in this AEG tracing in terms of seeing the EEG, and on the EEG we can see it's coming from the temporal lobe. You can also use the AEG to be able to again show the response or recovery after an insult. So this is a term baby after being transferred in for cooling, and here you have some seizures, and you can see how discontinuous and suppressed it is, and that amplitude changes, and that you start to get state changes as you go through cooling and rewarming. This is a patient who's on ECMO or had severe PPHN. They were placed on EEG due to concerns about their neurologic status. At this first black arrow is when the vital signs and clinically the patient became unstable, and the team made the medical decision to initiate ECMO. The second black arrow, you see a sudden flattening of the EEG tracing, suggesting the baby's in trouble. And then the third black arrow is when the EEG was disconnected for cannulation. And then with recannulation, you see there's almost immediate resumption of the EEG background to pre-ECMO levels, so that no matter how clinically concerning the patient may have looked or was behaving during this period before they went on ECMO, it wasn't sustained enough to have a significant impact on electrical function, therefore brain function of the baby. So pitfalls to be aware of in using AEG, that background voltages can appear elevated, and it may be artifact, but sometimes babies are actually in status epilepticus at the onset of recording, and therefore your whole upper and lower margins and your whole bandwidth will be elevated, and that's not baseline. That is actually status epilepticus. A voltage, your amplitude may be decreased, and it's not because there's any brain problem. It could be an impedance issue with severe scalp edema, dependent edema, cephalhematomas, subgaleal hematomas. Your electrodes are too close together, so that's going to make the amplitude falsely low. It could be that the patient is sedated for ECMO, or they have an open chest after coming out of the OR and therefore are paralyzed. And again, the limitations with brief seizures, overlapping, or a cluster of seizures spaced closely in time. AEG will have all the same technical limitations of the EEG. You do need to know about impedance and how to minimize impedance to get good electrical conductance. You need to know about interelectrode distance and how placing them too far or too close together will affect the amplitude of your AEG and EEG. Muscle artifacts, EKG artifacts, even just approaching the bedside can create magnetic and electrical artifacts that then translate to not just the EEG, but also the AEG tracing. And again, recognizing that there are many things that mimic seizures, whether padding, oscillators, and pumps, and that again, you need to look at the actual raw EEG data to be able to discern whether that is truly a seizure or not. Again, as I stated, many of the studies were so busy looking at whether the AEG picked up seizures as well as EEG, that very few studies actually looked at the overtreatment of patients with seizures because of overreading that AEG of artifacts and electrical artifacts as being seizures. Tips to avoid the common pitfalls: carefully place your electrodes, check the impedances regularly. For the AEG dedicated devices, they actually have very user-friendly displays to be able to monitor that in a easy and continual fashion. Remember to place event markers to inform the reviewer when certain events, procedures, activities such as padding or clonus or sedating medications were given, so that we know why there are changes in the background. And to also recognize that you should go to the EEG display. All the AEG dedicated devices will show you the raw EEG display, or you need to actually switch over to a full EEG to be able to discern what is actually going on. So in conclusion, prolonged continuous video EEG monitoring is a gold standard for monitoring an acutely ill newborn. And AEG is a reasonable, relatively simpler alternative when access to continuous EEG is limited to assess and monitor high-risk newborns. And AEG will have all the same technical limitations of the EEG. It doesn't mean that it doesn't have any, even though it is simpler. And AEG sensitivity and specificity for seizures will be less than an EEG, but it will help you identify which patient may be seizing. Prolonged continuous video EEG monitoring is recommended to detect and guide seizure treatment. And AEG sensitivity and specificity for outcome prognosis will be similar to an EEG. Thank you very much. And I think we can open to questions now.
Okay. So once again, thank you, Dr. Chang, for both beautiful two talks, very thought-provoking. So we have some questions from the participants. It is all over the world, so I'm trying to make it as concise as possible. So the first question is that related to your first talk, what is the best time for getting imaging, especially MRI brain?
So again, it depends on what your underlying condition is. If you have a baby that's coming over for cooling and there's a clear sentinel event, or again, if you're adhering to cooling criteria of there being severe or moderate acidosis, so you know there was an ongoing event, even if the onset of that may have been even before labor and delivery, but it was ongoing during labor and delivery, then the diffusion weighted images are going to be ideal at about 4 to 6 days post insult. So that would be post-birth. If you're talking about a stroke, again, or any other seizure baby where you don't have a clear etiology, you're looking for etiology. So then in which case you can get it after you've achieved seizure control. The MRI will not treat the seizure. So I think it's important that we stop the seizures first to prevent any additional brain injury and then get the MRI, because the issue is still going to be there. Whether you get that MRI sooner or later, but the brain injury may be going on if you don't treat the seizures effectively.
Okay, so thank you. The second question is that what is the role of follow-up MRI in a baby who get a stroke or some hematoma initial in his life?
So again, it's hard to give a universal statement because it all depends on the specific issue. But for the cooling babies, I don't get a follow-up MRI. Okay. To me, that's like looking at a scab. Yeah, you can look at it a week later, a month later. It will still be there or may have disappeared and faded. However, it doesn't mean it didn't happen, right? Okay. So the follow-up MRI, I feel, at least for me, has very little clinical utility. Just drives up the cost, but no clinical utility in prognosis.
Okay, that's very good. This is an interesting question, and it is from, I think, from the resident. He said, I'm early in my career. How reliable is my neurological exam?
So if it makes you feel better, when I first stepped into the NICU in 2004, I was like, wow, the neuro exam is worthless on a newborn. Mm-hmm. And during my first year in the NICU, I realized I was worthless at doing a neuro exam in a newborn. And so one of the benefits of being in a center where we do have very easy access to all our neurodiagnostic tools, it allows for very immediate biofeedback. So that now, after having cooled over 600 babies, seeing all their EEGs and all their MRIs, I can tell just by their movements when they come in, oh, that baby had to have had some basal ganglia injury because look at that movement. It's very disorganized and not smooth. That is a motor issue that has to be some basal ganglia insult.
Okay. The next question is regarding, actually you mentioned about the NIRS. So he said, how valuable is the NIRS technology in monitoring the neurological conditions? That's the question, I think.
Since I do have very easy access to continuous EEG, I don't find the NIRS very useful because it's less sensitive and specific than an EEG. Mm-hmm. However, my colleagues, my NICU colleagues, actually use the NIRS a lot for their PPHN, their cardiac patients, and really understanding how the circulation is going. So the only times I would say that I look at the NIRS is if I have a baby arriving and the story sounds horrible. It's a birth asphyxia baby, APGARs were 0, 0, 0, 0, pupils are fixed and dilated. In which case, I will have the neuro exam, I will have the EEG background, and I will also look at the NIRS. If the NIRS are above 90% and the pupils are non-reactive and the EEG is flat, I can go back to the family and say, even without a brain image, and say, okay, I'm confident, 3 different modalities that are not improving in that first 24 hours of cooling, therefore not turning around, not responding, that the cooling is not gonna change, it's too late, and that we can feel confident because there's 3 modalities. Obviously, brain image, go ahead and still get a brain image, but at that point you can get a CT scan, a head ultrasound. It really doesn't even matter because you don't need MRI to see devastating gross injury. You don't need MRI for that level of resolution.
Okay, so related to the same question, because this meeting and this conference going internationally, and I think it is from some of the low-income countries, there's a question is that we don't have access to MRI that easily. So should we depend on our neonatal examination, blood gas, or what else come to your mind that if we don't have the access to MRI easily?
So the question is then, do you have access to a head ultrasound or a CT? And I think when, our head of our radiology is actually one of the forerunners of doing neonatal head ultrasounds. And oftentimes what happens is head ultrasounds are done very poorly. You're not using the head ultrasound to its maximum capacity if you don't recognize that you can open up the windows of that transducer so that it's not just looking at the ventricles for IVH as if IVH is the only brain problem newborn has, but to open up as wide as possible that you can see as much of the brain, and not only side to side, but also open up the window all the way down so that you can see the whole posterior fossa. So you can see both cerebellar hemispheres, you can see the vermis, the fourth ventricle, and to do both a coronal as well as a sagittal view. And then you can also do a mastoid view to get a view of the posterior fossa. With those three views and then adding Doppler full images, that you can get a pretty comprehensive image. So we don't actually order CT scans anymore, because if you set the head ultrasound settings to its maximum capacity, I should be able to see all forms of herniation with the head ultrasound sufficiently. I do not need a CT scan for that.
That's very helpful. Thank you. Okay, the another question is also interesting, that is there any difference in neurological assessment when you are doing the EEG of term and near term neonates or the preterm neonates? Obviously.
Yeah, so the EEG changes a lot. You know, if you look at a 24-week EEG, you know, they have a burst of brain activity and then it can be flat for 10 or 20 seconds. If you saw that kind of EEG pattern on you or I, we would say, oh my, you must be in coma. That's burst suppression. That is not burst suppression in a newborn. So again, just, you know, EEG or A-EEG, because the electrographic activity changes so much, because these are initially just neurons, they're not connected, not talking to each other on the cortical surface. And then not only that, the neurons in the thalamus and basal ganglia are not yet connected to the cortical, that you don't get sleep-wake cycling. You don't get a lot of those state features that you would get in a more mature brain. And so the EEG changes. So, you know, when we train, you know, neurology fellows, when they're learning how to look at the EEG, I always say, try to guess the age of the patient just by the EEG. Don't look at the sheet of paper telling you what the gestational age is.
Sure. Okay. There's a question about the follow-up, that the baby has some insult and it's grow out and there is no seizure now. Do you advise to have a EEG later in the life when there is no active convulsion?
So let's take, for example, a cooling baby that comes in, has seizures, and then we stop all our seizure medications by, you know, post-cooling, even if they were on 3 or 4 medications. But you know from both their EEG, because it's very epileptiform because of the acute injury, and their MRI, there is extensive injury. Those are the kids that it is useful. There is literature from Japan, old literature decades ago, that show you that an EEG at discharge can help predict who is likely to go on and develop infantile spasms from the EEG background. For us, based upon our experience of knowing the clinical history, the EEG and the MRI, there are some patients we will automatically do a 3-month EEG, a 2-3-month EEG, where we're looking for very early features of them developing hips arrhythmia and infantile spasms, or actually developing seizures, and that we're very proactive, because we know whether it's in the NICU or outside of the NICU in outpatient neurology, the sooner you identify and treat, the better they seem to do. Your chances of having effective seizure control is better.
The last question, I think it is from my unit. So the question is that the 24-25 weeker has a second grade IVH and some abnormal movement, and somebody start phenobarb. Now the babies grow very well, everything okay, no BPD, nothing, and still the phenobarb continue. So what you do? You continue for a while, or you just discontinue, or start weaning? I mean, this is the everyday question.
Yeah, so the preemie baby, in terms of seizures and prematurities, I still feel like it's a very black hole, because we do not have enough information. What I do know is that when you're talking about that extreme preemie, they are very, very different than a term infant. Their seizure onset can occur much later than would occur. If you talk to Harvey Sarnet, the one of the authors of the Sarnet paper,
Sarnet, yeah.
He's a neuropathologist, right? He will tell you that he doesn't believe you can have seizures, cortical seizures, until about 3 weeks, just because there's not enough interconnections to generate an electrographic seizure. So I have seen that where the extreme preemies, they can get an insult and then months, like a month or two later, start developing seizures. But they're more like an acute symptomatic seizures because you treat it for a little while. We stop the medications before discharge and they don't come back in seizing because we withdrew the medication. So, and then the other difficult issue with the extreme preemies or even any preemie is that they can have myoclonic jerks as part of their sleep phenomenon. It is very hard to discern if those are sleep myoclonus versus seizures, because regular myoclonic epilepsy can have very little EEG signature as well, because the actual seizure is so brief that you don't get an EEG, capture any EEG changes. And so I hesitate to just treat myoclonic jerks in the preemie by throwing seizure medications on them. Exactly. One thing that that will be coming out into publication very soon in Epilepsia, it just got accepted, what is our data from the Neonatal Seizure Consortium. These are 9 centers across the US. And we looked at how each center, how they manage their seizure drugs. And it shows that whether you discontinue them prior to discharge or continue them afterwards, it does not make a difference. It does not worsen your outcome. It does not increase your incidence of developing post-neonatal epilepsy. And it does not mean that you're going to start your epilepsy sooner. So there's actually no benefit of maintaining the anticonvulsant drug.
Okay, there are a lot of questions. I will give your email and they can email you